Good morning. We like to welcome our affiliates that may be joining us remotely. And I have the pleasure of introducing our speaker today, who's Dr. Les Miller. And he asked me specifically not to talk about his history, but I will just give you a small anecdote. Because I've known Les for, I guess, I don't know, maybe over 20 years or maybe more since I was a fellow. And heart failure and transplantation was not what it is today. Heart failure was, or transplant was maybe the interest of a few surgeons, a few cardiologists, but it has morphed into a very great field. And today we have boards, we have a specialty. I actually just saw recently we are going to have a designation of like FACC. Now we're going to have a FA something. I don't know what it is, but I don't know if it's marketing or it's reality, but the truth is that the field has grown a lot. But years ago, when I was a fellow, there were only a few people that were senior that were in the field dedicated full-time. And Les was among those. And at that time, you, Junior, would see these guys, and maybe not that older than me, but more senior. And there were very few. It was a very small community. I remember the very first Heart Failure Society meeting was just 5, 6, 7 guys, and a few girls, maybe. And it was a very small group of people that now has expanded into a great field. And I guess the only thing I would say to you is that in my career, I have related to people like Les to the years and found extraordinary help and collaboration to the years. And so I'm very grateful that you're here today and sharing with you a little bit of your experience and your new research interest. Thank you, Les.
Thanks, Guillermo. Thank you very much, Guillermo. I want to pause to begin and say how pleased I am to have been invited here to your extraordinary program, but also to stop to acknowledge that one of the joys of academic medicine is establishing friendships that have existed since some of them were fellows. But it's really a joy to see all that Guillermo has done to contribute to this program and has contributed in so many ways in giving back in Monterey and the MD PhD program and mentoring and being a real mensch to the junior faculty. And so it's really one of my most esteemed colleagues and a real pleasure to say as a great friend. And so it's really a pleasure to be here and want to acknowledge your contribution. I'm going to start by being somewhat provocative, and I would suggest to you that hopefully by the end you'll get some belief in the concept that within 5 years this is going to be in mainstream clinical application, the concept of regenerative medicine. So if we look in biology and in nature, many of you may be aware that if the newt has their forearm amputated, within 6 weeks they regenerate a complete new extremity. And it's interesting that you can amputate at various levels, and they will reconstitute exactly what they need in a relatively modest period of time. So it's a clear lesson that the concept of repair and regeneration has gone on for a long time. And I wanted to start with the concept of regenerative medicine is the body's primary mechanism of repair of any damage to tissue, organs, or vessels. And we're not talking about its obvious application in cardiovascular, but as you'll see through this talk, this has application to almost any acute or chronic disease in existence. And those trials with stem cells, gene therapy, and so forth are ongoing. When we look at the heart, the concept that it could hypertrophy, but was hyperplasia a component as well, is really based on the observation of apoptosis, and I think people would variably say between 3 or 5% of your cells in the heart turn over every year. And so there must be a regenerative capacity that's there, but I think what we've learned is that it's a relatively inefficient. When you're only turning over at that over the course of a year, it is challenging to get it to rev up to be as effective as we'd like it to be. To define a stem cell, there are really two basic or fundamental characteristics. One is that it's capable of endless rejuvenation or regeneration in perpetuity. And second, that it's able to differentiate into any of the tissue types in the body. And I've highlighted in yellow from a cardiovascular point of view some of those cell lines that we would think would be most important. But this led to our relatively naive understanding that if you had an injury, let's say it's a myocardial infarction, it would lead to a stimulation of the bone marrow. Those stem cells would come out of the bone marrow and try to achieve repair of that injury. and if it was a pneumonia or it was hepatitis, those cells would come out and be differentiated into that lineage that was needed based on local factors. And while that may have some relevance, I think we'll come back to understanding more about a local lineage-specific cell. The mechanisms involved have evolved in the last 10, 15 years rather significantly. As I suggested, we thought we could simply transplant cells that had a predisposition like myoblasts, and they would become cardiomyocytes. And no matter what cell we've transplanted, there's very little evidence to suggest that there's a direct myogenesis effect that's being seen. But we know they have other major attributes, including anti-inflammatory, immune modulatory. Think about graft versus host disease, where it's being used as a primary therapy in some of the earliest approvals. It's really an incredibly effective, largely regulating regulatory T cells, but has significant immunomodulation, anti-apoptotic. But one of the features that most of these cell types have is they're very proangiogenic. And I think we understand that perhaps many people would say to you that the most important mechanism is a paracrine mechanism. This cartoon is rather simplified, but what it suggests is that when we give stem cells, they really don't stay but for 1 or 2 days. Imagine implanting 50 million cells and tracking them, and they're gone within 2 to 3 days, 90 or 95% of them. So it is not the stem cell that we transplant that mediates the benefit that we see. It's that they're turning on native repair, leading to the benefit that we see because these cells are gone. A very elegant way to remember this is Vic Zhao took cells in culture for 2 weeks and then took the effluent off the culture medium and used that as his therapeutic vehicle. It was as effective as the cells themselves. So it's really proof positive. It's what the cells are secreting and what they're initiating at the local level rather than the stem cells themselves. Well, I'll begin with when we started this field now over 12 years ago. We thought there were 2 basic sources of stem cells, the bone marrow and embryonic, and we stayed away from that to some degree, but bone marrow became the logical starting point given 20 years of bone marrow transplantation. And we started with acute myocardial infarction, still the leading single cause of death in the world, and did what we now I refer to as drive-by therapy, that we would flush these cells back into a reopened artery in a single bolus administration down the coronary and infarct-related artery and hope that during those circulations they would come back and home. And the concept is that whenever there's injury, there are a number of cytokines and chemokines and other factors that serve as significant homing signals to any stem cells mobilized both locally and from the bone marrow that would achieve that repair. And so that was somewhat naive in that we could just flush these cells down the coronary. This is a fairly important meta-analysis, as one of the primary people in the field has observed there are more meta-analysis than there are trials in acute MI therapy. And I think they keep retreading what we learned in the early autologous cells from the bone marrow. We've looked at the whole mononuclear fraction, the endothelial progenitor cells, the smooth muscle progenitor cells, various cocktails out of the bone marrow. But those trials did not result in a very significant, although met statistically significant, an average of a 2% improvement in ejection fraction as the primary surrogate. But appreciate the fact that we took everybody in a trial. And maybe your EF was 49%, that you were intervened on early on, there was very little injury, and so you went to 52%. It's a, so what? That's a lot of manipulation to do a bone marrow and spin it and give it back to the patient. We didn't understand when you should give it. Is it within 24 hours, or should you let the inflammatory signal settle down? And we looked at 7 days and 14 days, and we've really worked on a lot of different parameters as well as the number of cells. But what we learned that was somewhat consistent with this, the size of the infarct was better correlated with the benefit and change in EF that you saw, and the concept being that it was more of a release of more homing signals, more of those stem cells went to repair that infarct, and so it supported that. But when you drop back and ask, well, this is a disease of older people, so to speak, and perhaps age is going to be a limitation, and I'll talk a little bit more about that. But we've come a long way in this area, and it really is one of the observations I want you to think about, and that is that we're no longer doing pilot trials. There is a trial called BAMI that's going on in Europe right now, 3,000 patient trial of bone marrow in acute myocardial infarction. I think that will put an end to all of the discussion of its role in subset analysis or planned and a lot of things that we didn't have in place in the first round. But this is an important slide from Arnie Kaplan. That's not a surprise when you think about it, that aging and senescence has a lot of effects on the body in general, but it has a significant effect in reducing the number of stem cells that are available in the bone marrow to be mobilized. And work from Doris Taylor and others have said not only that in the bone marrow, but those number of cells are also proportionately diminished in the circulation. And lastly, if you look at chronic lung disease, chronic kidney disease, and many other chronic conditions, those comorbidities also cause a decline in the function of those cells. And so we take someone who's chronically ill at 60 or 70 years of age and want to use their cells, I think the days of simple autologous cell therapy have probably come and gone in its current iteration. So we moved out of the acute myocardial infarction area, and the NIH sponsored a trial called FOCUS, which for our interest was focused on heart failure. And this was chronic ischemic stable heart failure. So unlike the acute myocardial infarction, where we postulate that there's a big inflammatory signal that would bring the cells to that area, this is a completely stable post-infarct population. And so they gave them 100 million cells in a randomized trial and now developed technology called NOGA catheter, which is the delivery of endomyocardial delivery of these cells. And it looks somewhat like this, where you see the needles from the NOGA catheter and a newer iteration, which is a corkscrew, which may give it more fixation and better deposit of the cells. But we're able to do this with pretty significant sophisticated mapping. Even echo can be reasonable, but looking at infarct areas and going in the peri-infarct area, and you can direct this catheter within millimeters of the target area. And so we really advanced in our technology for chronic stable cardiac failure. But the endpoint of the trial was that it didn't meet any of the primary endpoints. And when we did a subset analysis, another observation about the apparently important role of age, if you did a cut point analysis at greater than or less than 62 years of age, you can see greater than 62 years of age as a mean had no change in ejection fraction, as opposed to 5% in those less than 62 years of age. So it really had a significant effect in the field of saying we need to move out of our current thinking of just autologous bone marrow to potentially go forward. But I want to make one important point here in a learning process is that Doris Taylor, when she was running the NIH biorepository from all of those patients in these trials, looked at the correlates in the bone marrow of the better responders. And they found that the number of CD34 cells in the bone marrow was a pretty good predictor of that. That information has gone now to a trial called CardiAMP, in which they're going to screen that you're eligible by virtue of your ejection fraction and so forth to be treated, but you get a bone marrow, and if your bone marrow doesn't meet a minimum number of CD34 cells, you won't be enrolled in the trial. So we're learning to treat the people that are most likely to respond. But I learned another lesson about one of the seminal contributions that Dr. Torre has put in the field. It was a young individual, Dr. Retrovec, who was here and worked with Guillermo early on in looking at the concept of non-ischemic heart failure. Half of the population is non-ischemic. Theoretically, all those myocytes have the potential to recover and maybe even a better target population. And he studied 110 patients and looked at a fairly significant population, EF less than 25%, very high BNP, very dilated hearts, so a pretty advanced heart failure group, and gave them bone marrow-derived CD34 endothelial progenitor cells. And the most important part for those of you interested in heart failure, this is by far the best data that has ever been published on the benefit of an intervention in people with advanced heart failure. This is 6-year follow-up data, and they really had a fairly good recovery of all the patients in the trial. But look at these endpoints. Survival, 6 years after treatment. There are many of these patients you would presume would die given this phenotype. The ejection fraction improved at 7%, and the functional improvement in terms of 6-minute walk, New York Heart Association, and other parameters, the risk of sudden death, all of the parameters that were involved in this trial are really profound. And you'd say, This is an endothelial progenitor cell. Why would that enhance myocardial function? I think we're learning this interaction of CD34s and other myogenic components to this, but this data stands there as what could be possible. This was done in 2007 and followed up, and I think in our current thinking, this is really a population we need to continue to explore. But it led to this really big departure and much greater thinking about other ways we might advance this field, including new sources, switching to potentially an allogeneic source, and some rather provocative new science. So I showed you the first slide that we had bone marrow and embryos, and now look where we are today. It's been an explosion of new sources that will still include bone marrow, but genetically engineering somatic cells, looking at resident progenitor cells, adipose tissue, a really unusual source, but really a very high dense population of stem cells, but also umbilical cord, getting away from the controversy of embryonic, but taking cells while they're still quite capable of differentiating into any other cell line and easily obtained, and really quite a progressive field. Placenta and amniotic fluid, even the very proangiogenic menstrual cells, and a bit of work still ongoing in the area of embryonic. Well, we've been involved with a trial called Athena that was based on using adipose-derived stem cells, again, an unusual reservoir, particularly the abdominal fat compared to other areas in the body. And these cells can be harvested by a plastic surgeon doing a standard liposuction and exposed to collagenase and a centrifuge for about an hour, and it completely dissolves away the fat tissue, and you're left with a pellet, like this is shown, that can be directly injected into the myocardium. This is a look at a nuclear scan just to give you a sense of a single administration of 50 million adipose-derived stem cells in a patient with a pretty significant ischemic anterior wall, and here at 3 months afterward. We're not talking about building new conduit vessels, but the stimulation in a broad distribution in that particular target area led to a rather, I think, impressive improvement in myocardial perfusion. It went from showing it was very effective in enhancing coronary blood flow and ventricular function when adipose cells were given in the time of an infarct, and they moved to this trial called PRECISE, in which they gave it to elective ischemic heart failure stable patients and showed a significant reduction in comparison to control patients in the natural history of increasing end-diastolic volume post-infarct. And I think one of the hardest endpoints to achieve is a change in peak oxygen consumption. And I think you can see, even though the patients who got cells had a worse peak VO2 at baseline, this is the natural history of the untreated control patients with a progressive decline. In contrast, at 6 months, 12 months, and persisting at 18 months, this benefit and improvement in function was seen, which is quite hard to see it go forward, and was brought forward in the United States. It was a very interesting concept of enrolling patients in this trial and explaining to them that they would need to have a liposuction to be able to qualify for the trial, and both hands would go up and feel free to take all of mine, and you can do this. And a couple ladies looked at me just back-to-back week and said, "Now you're going to do both sides, right?" You know, yeah, I think we got this understood. I mentioned before is another source that you're going to hear a lot more about is umbilical cord cells, because there's a huge history of preserving umbilical cords for 20 or 30 years. There's an endless population. These are going to be discarded, and yet these are perhaps some of the most robust cells that we can use. And when you look at a cell bank, while we would think about those as this classic, you know, you're later on, or your sibling needs a bone marrow transplant, there are really more of these cells being preserved now to use for regenerative medicine than any other application. So you're going to hear a lot more about this source of stem cells. One of the most important advances in the field in the last 5 years is a complete change in our understanding. I suggested to you that if there's an injury, bone marrow cells are mobilized, they home to the area of injury, and they differentiate into the lineage required. We now understand that biology is a lot simpler in that every organ has its own lineage-specific resident progenitor cell, the heart included, but brain, lung, liver, kidney, all organs have their lineage-specific cell. And several investigators have identified at least 2 in the heart. We don't need 1, we need 2, referred to as the c-Kit cell, but Eduardo Marban did endomyocardial biopsy and put those cells in culture and found that they grew into a globe, and so he refers to them as a cardiosphere. and did a trial called CADUCEUS, and the c-Kit cells have also been in clinical trial arrays. So we've gone fairly rapidly from the lab to clinical application. So I show you this trial called CADUCEUS, and I think it's quite important in terms of its benefit of looking at the possible benefit of cardiac lineage-specific progenitor cells. They did an endomyocardial biopsy, grew up these cells within weeks, and then randomized them 3-to-1 to cells versus placebo. One of the most incredible observations that has been reproduced is that they showed a regression in scar, infarct scar, by quantitative MRI. We know these cells also have an antifibrotic component, but this was a rather profound observation. It was shown in association with a 25% improvement in ejection fraction, positive remodeling ventricular size and volume. And that phase 1 trial led now to a phase 2b trial called All-Star that's up and actively enrolling right now, in which cardiac progenitor cells are being used as a method of treating patients with systolic heart failure. The importance of this is that they were using, again, the patient's autologous cells because that was their initial observation. But the concept that age and other things make it harder to process, they've now moved to developing an allogeneic source, and these cells do not seem to have much of an immune stimulation, and so this trial is out there without any immunosuppression and is enrolling, and we hope that this will go quickly from a 2B to a phase 3 definitive trial. A second rather profound change was our understanding about the ability to manipulate cells and transform them with the addition of transcription factors. This came off the original observations by Yamanaka in 2008 that adding 4 transcription factors could take a skin fibroblast and transform it into an inducible pluripotent cell. Rather almost unimaginable, relatively simplistic, but the biology has been reaffirmed by a number of people and led to his Nobel Prize. But what Andrei Terzik has really understood is that many patients don't have a very pro-regenerative profile for comorbidities, for a variety of reasons. And so his premise was that you could take bone marrow MSCs and derive them into a cardiomyocyte-directed lineage, and that is this concept of cardiopoiesis. And as you can see here, he too has developed a cocktail of about 6 or 7 transcription factors that, when added to these cells in culture, not only cause translocation of these transcription factors into the nucleus of this cell, but it then differentiates into a totally functional cardiomyocyte, referred to as cardiopoiesis. Well, this too went from the lab quickly into a clinical trial, as most things done in Europe before it can come into the United States. But I draw your attention to the same observation I mentioned before, almost a 25% reduction in LV scar. So we now have what we thought was intractable infarcted fibrotic myocardium that looks like there's a potential to cause that to regress and theoretically be replaced by new functioning myocardium. They said almost a similar improvement in ejection fraction and change in remodeling. This trial was moved from a phase 2 to a phase 3 in Europe. It's been completely enrolled, and we'll have the data from this trial probably not by the ACC, but by early summer. The U.S. phase 3 trial is to start in the first quarter of this year. But just to give you this sense of how rapidly these innovative ideas in stem cell therapy are moving right out of the laboratory because of their safety into the clinical arena. This comes back to the last of the genetic engineering, and it really reflects what I said to you before, that Yamanaka was the originator of this cocktail, these 4 transcription factors that, when added to a skin fibroblast, could develop into what's referred to as an inducible pluripotent cell. Pluripotent meaning that concept, this is truly a stem cell that can differentiate into any cell lineage that you're interested in particular with adding a few different transcription factors, can be differentiated into a functional cardiomyocyte. You'll hear a lot more in the next several years about IPS cells, inducible pluripotent cells, because we now have the ability to do disease-specific drug screening. Imagine we take all patients with amyloid, all patients with other etiologies, and now look at their cells collectively rather than saying we have a population with 10 different etiologies of their heart failure, but we can study disease-specific, and this is a rapid throughput that is really, I think, going to play a major role. It will also allow us to develop cells for treatment in patients, and I think you're going to see a number of applications of these so-called iPS cells. They, as of yet, have not gone to the clinical arena because there is some modulation of their surface markers, and they're somewhat immunogenic, but I think that that's being addressed rather aggressively. But the cell that I think you'll hear the most about and that I hope you will focus on is the mesenchymal stem cell. This is what Arnie Kaplan refers to as the injury drugstore. Whenever you have an injury in the body, this is the cell that mobilizes all of the homing, upregulates the chemokines on the surface of these cells so that they're drawn to the area of injury and play a major role in almost any type of injury anywhere in the body. We also understand that this is like any stem cell is capable of differentiating into bone and cartilage as well as cardiac and other lineages, but is of particular interest to us in the sense that it's proangiogenic and it has the potential to develop in cardiomyocyte generation. It can be drawn from the bone marrow as a classic. We never looked at that subpopulation when we were doing all the bone marrow autologous therapy, but when you isolate the MSC, you can get it from bone marrow, you can get it from fat, and you can get it from the umbilical cord. So this cell type is probably the cell you're going to hear the most about. Kaplan has shown that this is not a cell sitting in the tissue, but it's actually on the surface of all blood vessels. And when injury occurs, these cells are removed and come into a free state in which they differentiate into a regenerative type of mesenchymal type stem cell that again can differentiate in any cell lineage. But this is kind of a real advance in our understanding of what the MSC does. But just to give you a sense, I mentioned early on that this cell therapy is going in a very rapid clip. If you just Google clinicaltrials.gov stem cells, 5,000 active trials going on in the world. If you drop back to MSCs, there are 108 trials going on in the United States right now, a large degree in China, in Europe, around the world. So you get a sense that there are these 565 MSC-specific applications. You can appreciate how broad the application of this type of cell because it has this broad differentiation capability. But what's most unique is that it does not seem to express co-stimulatory molecules on its surface, which is what your immune system recognizes as self and non-self. And the importance of that is that we refer to this now as immune privileged in the sense that we can give you my cells without immunosuppression. Cell therapy is a form of transplantation. And if we could give somebody cells from an ideal donor and have no need for any immunosuppression, looking at allospecific antibody generation, other markers of immune stimulation, they don't last but for about a month in about 4% of the patients and don't have any long-term adverse effects because we're putting them right in the heart. We don't want a localized immune response, and we don't seem to see it. So it's almost too good to be true, but this allogeneic MSC allows us to now have an off-the-shelf ideal donor. Imagine your 65-year-old guy with chronic heart failure giving him his cells back versus a 20-year-old perfectly screened, ideal, healthy individual. This is a game changer. In any organ, in any discipline, in any indication, you'll be able to use allogeneic MSCs. You can guess that this came rapidly, well, relatively rapidly, probably 10 or 12 years of actual clinical trials, but Josh Hare and others in the field have led a number of trials that have shown and proved that these cells in the allogeneic are as effective as ideal autologous cells, so we know we're not giving an inferior product even though you don't need immunosuppression. There have been trials using it in left ventricular assist devices, and one interesting observation is that we thought we could just give a specific cell and the heart would say, well, that's all I need and I'll replicate. But we understand that one of the other things that the MSC does is stimulate the cardiac progenitor cell, the so-called c-KIT. And so now we've got a trial randomizing between the c-KIT, the MSC control, or the two together. And there's good animal data suggesting that these MSCs in conjunction with native progenitor cells may really make those progenitor cells much more effective. Appreciate the sequence of typical FDA regulation of clinical trials. There was a phase 2A trial. So you've gone beyond a pilot into the first clinical trial of 75 patients called Revascor. And this is using this allogeneic MSC in chronic stable heart failure. This trial went to completion, and for the first time that I'm aware of, at a 2-year endpoint, when they looked at adverse events in a dose-dependent manner, they gave 25 million cells, 75 million cells, and 150 million cells. In the largest dose, they had no documented adverse events. It's about the first time I've ever seen that happen. Obviously, it's a well-controlled, very regulated, reviewed trial. That let them go from a phase 2A in 75 patients to a 1,700-patient worldwide phase 3 trial. This is positive. It goes to commercialization. Again, the sense of how rapidly the field is moving, but it's based on the safety and the efficacy shown and the lack of toxicity that has allowed this cell to really move forward, the DREAM study. And I think that Barry was telling me that you're going to bring it to your institution. I think it's truly a game changer, what we had for the treatment of heart failure. I mentioned LVAD patients. I think that's the most ideal platform to study any kind of therapy because they're relatively safe and stable and they're unloaded, and so you can do what you want. But imagine if you could give those allogeneic MSCs at the time you do an LVAD implant. Or now we might be able to give it later if you think there's an inflammatory component. They did a pilot trial just like before with 25 million cells and suggested that it had quite a benefit in time and stability off an LVAD. This is 25 million. As like with Revascor, the phase 2B trial of MSCs with an LVAD now is 150 million cells. So that this benefit, imagine multiplying the cell number by 6 and imagine the potential that we can see in this circumstance that we might be able to, and you're going to see this as cardiac surgeons as an adjunct to bypass surgery, valve repairs, many things where there's LV dysfunction, these cells can be used at the time. Well, delivery is kind of the heart and soul of a lot of the technology involved in cardiovascular therapy, and we've gone from intravenous. People would ask, well, why don't you just give the cells intravenously, or is that how you do it? The lung is an incredible filter, and in one pass, 75% of the cells, if we gave them intravenously, are picked up in the lung. And in the next circulation, the liver picks up about a third of that, and the next circulation, the spleen picks up. So you don't really get much local delivery if you just gave cells intravenously. We then moved to intracoronary. We then moved to endomyocardial. And I think that the game changer that I think you're going to see is twofold. One is a very novel catheter. For those of you who are interventionalists, I think you'll see the uniqueness of this type of catheter that literally goes transcoronary. You can manipulate a needle that's sitting on the top of a balloon, and when you inflate the balloon, it perforates the coronary artery and allows you to inject directly into the myocardial tissue. This is relatively safe. You simply deflate the balloon, pulls the needle back down, it seals itself, and there's no adverse effects in the coronary. There's been no dissection with its use. But take a look at what it might show you. Here's a look at the change in ejection fraction in 5 trials using bone marrow cells, and as I suggested, you can see it's somewhere in the range of 2 or 3% average improvement. When this was done in a pilot trial with patients with an acute MI who had an EF less than 45%, 12.5% improvement in ejection fraction using another new multipotent progenitor cell from the bone marrow. So the cell has its unique potential potency, but I think this kind of delivery in an atraumatic way to literally perforate the coronary and inject right into the infarct zone is another potentially significant advance, particularly in acute MI therapy. But as I mentioned to some of the colleagues last night, one of the things that we have to appreciate is heart failure is still one of the global causes of death and prevalence in the world. And we can't stay at high-tech university, major hospital sites and deliver the kind of therapy that this potentially could represent in a low cost. We're not going to take transplants and LVADs into lower economic areas. But 3 companies have now developed a preformed catheter that you can go from the right femoral vein and go up and preform manner get into the coronary sinus and inflate the balloon. Now, those of you who are thinking of what I'm saying is that you're suddenly going to stop coronary effluent, right? This is the coronary sinus. You're draining all the venous drainage of the heart. We learned this about 15 years ago when someone was interested in this in Minnesota, and they said, well, what would happen to a pig? And so we had a pig model, and they inflated the balloon, totally stopped coronary blood flow as we understood it. There was no perturbation whatsoever, no change in heart rate, no change in blood pressure, nothing, no rhythm problems for over an hour. And so we took that information and went back into 700 patients in Peru, and we had absolutely no traumatic problems. They had no perturbations hemodynamically. And so now we can inflate the balloon, and where does that blood flow go? Remember the thespian veins? Instantaneously, you can stop. The perfusionists understand what's going on there when you do a coronary sinus injection. But that's what's really going to change this, is the ease of having a preformed catheter with a C-arm potentially and inject these cells under a little bit of pressure so they have a uniform uptake within the myocardium. And I think this is really a significant advance in the field. And there are trials. Some of the newer agents that are coming have had all their preclinical using coronary sinus delivery of both stem cells and genes. Another major game changer is, imagine if you saw chemotherapy and it was one round, one time, and that's it, and you don't have a second alternative. Everything that you've read, everything you've heard about cell therapy is based on a single administration. And as I've tried to suggest to you, we probably underdosed many of them. We may not have had the best route. We may not have had the best cell. But now, any of these therapies can be given. We have the first trial in the United States with gene therapy giving a second administration at 6 months and 12 months with the concept that you could randomize patients to placebo and theoretically have very minimal change in ejection fraction at 6 months. And then the benefit is that both cohorts, the randomized placebo and those initially treated, would get a round of cells and hopefully see that this still has a persisting benefit in patients and that there's this incremental benefit with a second delivery. They're safe, both stem cells and genes, and I think this is going to be another major advance in the field in any application. So I want to try and give you a sense in a very capsuled manner of some of the progress now outside of the specific things that I've shown you. And I think that, in talking with John Cook, and one of the leaders in this field for sure, is that one of the concepts that age, when I showed you the decline in the number of measured mesenchymal cells, for example, in the bone marrow with age, is the concept of senescence. And we see a lot of dysfunction, whether it's as frailty or specific diseases. We know that their telomeres decline with age. And there are several initiatives going on, including telomerase, nucleostamin, a lot of things are going on trying to repair and normalize telomeres so that they could begin to respond more appropriately than when we've been giving cells before. You're going to see an awful lot about microRNAs, and there are at least 4 that are in clinical, beginning clinical trials in Europe of microRNAs or exosomes, the products of these cells, that we're giving that back with that same concept. It's what the cells are secreting, and maybe we're down to an even more effective mediator. We're looking at these cells. When the cells are in the bone marrow, they're in about a 10% oxygen tension environment. And when we put them in tissues, it's even less. So in our culture, we've been typically at 20%. And so now we're putting cells in culture at 1 to 2% oxygen tension, really giving them hypoxic stimulus. And it turns out that they upregulate a number of surface markers that are very beneficial, that we can do shock to these cells, a number of manipulations of the cells while they're in culture that may enhance them. And finally, I think really exciting concept, like you're seeing with immunotherapy, is that if you could paint these stem cells with an antibody going exactly where you want them to go in the heart or the blood vessels or whatever, that concept is getting really broad application. One last thing I want to show you is that stromal-derived factor 1 is a very important gene that is really critical in the homing of stem cells to a site of injury, the heart included. We now have an ability to use this as an assay of, we take cells from Mr. Jones, and in culture we can expose them to SDF and look how rapidly they mobilize as a segregator of your cells are you may have a reasonable number, but they don't function very well. And we have a functional assay that would say, no, not a good choice for this particular patient. So we developed functional assays that I think will take us much further into who we treat. So I want to, in the last few minutes, move away from cell therapy, which has gotten a lot of the limelight of regenerative medicine, into the concept of gene therapy. And if you remember the early cartoon that I showed you, if we gave stem cells, they would go into the heart and release a number of paracrine factors that stimulate native repair. Well, that concept says that most of that native repair is actually mediated by specific genes. And so a number of investigators have said, what if we essentially bypass using the stem cell as the vehicle and just give a high dose of that targeted gene? Could we, in fact, achieve the same benefit? Another field that has really exploded, you may have seen the early results from the CIRCA-2A, which was somewhat surprising. It's had a tremendous history in preclinical of enhancing and rescuing heart failure from a variety of circumstances. But you're going to see this adenyl cyclase, stromal-derived factor 1, neuroregulant. A lot of these are calcium-handling protein related. Some of them are simply energy. You're going to see a lot about S100A and ribonuclease enhancing ATP in the heart directly in the setting of stable heart failure. But you also see things like an acute myocardial infarction where you're saying, what is the problem with hypoxia and a big inflammatory infiltrate? And can we enhance the retention of these cells and viability of these cells when we give them an acute myocardial infarction? So if you're a cell therapy person or you're a gene therapy person, you have a happy medium in that there's already a clinical trial, a phase 2B going on in Canada in which they've transfected nitric oxide synthase into endothelial progenitor cells in patients with acute MI. So you're getting a very revved up endothelial support gene on top of cell therapy to help recover these patients. So again, these concepts have gone fairly rapidly from proof of concept in the lab into the clinical arena because they have not exhibited any toxicity. And maybe this says it all. This field is really moving very rapidly in terms of how many trials are all the way out to phase 3 and in large trials, and how many are on their way into clinical utility. Excuse me. But the last part may in fact turn out to be one of the most important pieces of the puzzle that we now understand, and that is the role of tissue engineering and specifically extracellular matrix. We wanted to give a specific cell, we wanted to give a specific gene, but in the myocardium, extracellular matrix makes up 40 to 50% of the net cardiac structure. And so, as Doris Taylor would say, it directs the orchestra. It is giving the cues to native repair. And that's been proven in a number of ways in which we've used tissue engineering to develop scaffolds, stents, and patches and a variety of ways to deliver cells or extracellular matrix. One hydrogel that can be injected in the heart is referred to as Allogeneic. It's a Texas company that has already gone into clinical trial. It was just reported in the American Heart Association called Augment, and a rather impressive, significant improvement in peak oxygen consumption in this randomized trial, and functional improvement that's going to go on to a 2B large-scale trial. So again, here's a concept about using a hydrogel that stimulates when it's injected into the myocardium. They sense it as injury and mobilize all the native repair. But a second one that I think may even eclipse that is actually delivering as a gel extracellular matrix. And this is from Karen Crispin's work and her company Ventrix, which is into a phase 1 safety trial that's just about to be completed and move into a 2A of actually being able to deliver this in a liquid form, and when it hits the temperature of the heart, it gets into a gel that is inert, but it again stimulates myocardial regeneration and repair. This is a sense of using this as a scaffold for stem cells. So imagine if you think the matrix is important, what about if we didn't wait on cells being mobilized? We could actually put the cells into that scaffold and then inject it into the myocardium. Imagine those that are interventionalists about using stents that are covered with stem cells or matrix and stem cells embedded as a repair of almost any type of vascular process. So one of the people that I think has made a lot of contributions in the field is Doris Taylor across the street at the Texas Heart Institute. And she's moved extracellular matrix from a gel to a patch, if you will, on the surface of the heart. And you can see in this, compared to controls, when you have a patch with or without cells at this endpoint after an infarct model, that this surface covering patch has a very significant improvement in functional ejection fraction in this porcine model. But the last thing I wanted to make you aware of is the concept that Doris was probably the originator of the concept of organogenesis. This is a very interesting concept that she developed while she was at Minnesota in terms of saying, what if we could decellularize using a detergent and take every cell out of the heart, vascular, around valves, in the conduit vessels, etc., myocytes, and you're left with simply this ghost white scaffold seen here. And she's gone from a rodent model to a porcine model to actually human cadaver and able to decellularize hearts, livers, lungs, kidneys. The concept of a detergent decellularizing an organ is unequivocal. She then takes this and puts it into a bioreactor in which she now infuses stem cells. Without any direction, without any, okay, now we're working on the vasculature today, let's give endothelial cells. Or now we have a myoblast and we want to develop myocytes. This develops into a rather sophisticated and functional. Been a lot of nuances about this. The valves are really quite sophisticated, and that took a little bit of time. The conduction system, when they began pacing it, accelerated that repair. But as Doris would say, give stem cells and get out of the way. The body understands and takes the cues of what these stem cells can derive, and you go from this ghost white to this functional. And they now have porcine models of these cellular organs in clinical trials in their labs at this time. So whatever area of cardiology that you are in or interested in right now, I think you're going to find an application of stem cells probably within the next 4 or 5 years in a clinical setting. The acute MI trials are being redone with the concept of this catheter to deliver it right into the infarcted tissue. A very important cohort. There's 2 trials going with a stem cell and a gene therapy in non-STEMI infarcts because of their increased risk of adverse events at 1 year. Chronic angina, again, with stents or stem cells alone, I think you're going to see this as really have a real application in the cath lab. Extended to carotids, extended to peripheral arterial disease. This concept of how these cells can repair vascular injury or disease is quite significant. A lot of this work on individual development of bioartificial heart valves using stem cells. No one could leave atrial fibrillation alone. And so there's actually some interesting work of using these cells both for atrial fibrillation and for ventricular arrhythmia because they have this pacification, whether it's anti-inflammatory or anti-fibrotic or what they are healing in animal models. It looks quite encouraging. Hypoplastic left heart syndrome is already in clinical trial at Mayo Clinic and several of their sites of actually regenerating functioning myocardium and preserving some of their time to need an operation. And as I said, cardiac surgeons shouldn't see this as yet another pull away from therapeutic intervention. I think that this is a typical application you'll see probably as a patch on the surface of the heart rather than epicardial injection, but I think it has an application in most cardiac surgery, particularly if there's any impairment in ventricular function. So what I've tried to give you a sense is that we've learned a lot of lessons in the last 10 years. Many people would say that you could have solved those in the preclinical arena. We should have known that first. But I think we've been able to do clinical trials safe without any adverse effects directly related to the cell or the gene. And we've understood that the cell source is not just simply bone marrow, but all of the different sources I referred to you. Mesenchymal stem cells, allogeneic source, many of those things have changed dramatically. We're still up titrating the number of cells we're delivering. We understand a lot about the donor themselves and the importance of that and why an allogeneic source may become better. But we have tools such as telomerase in repairing senescent changes and other factors that we can assess the quality of the cells. Several new, I think, are going to be game-changing kinds of delivery routes that we have developed. But really focusing on retention. If you're only giving a cell that lasts for 2 days, it's kind of naive to think that we're going to have the kind of profound benefit we want to see. But I think these extracellular matrix and the tissue engineering has given us tools to be able to enhance that retention rather profoundly, and understanding the heart is a combination of cells and matrix and fibrosis, and I think using all of those constitutive critical parts is how we're going to be successful in the future. So in summary, I think that we have really come to understand what is a primary biologic process. We're not using a logical drug pathway. We're using the body's native primary repair mechanism, and we're just learning to harness that. I think without question, this is a safe therapy. There's almost nothing that has been shown as a direct toxicity from the cell or a gene that's been delivered, or even matrix as we know it thus far. I think that while we had a very modest early beginning in acute myocardial infarction, those trials were small, they were underpowered, and I think you're going to see these bigger trials I've tried to show you now as phase 2B and phase 3, 1,700 and 3,000. We're making very rapid progress to give a database that will warrant its expansion in therapy. And I think that the Churchill concept of not that we're at the beginning of the end, I think we're at the end of the beginning. I think it's a whole new era. I think what I've tried to show you is the advances in the field in the last 5 to 10 years are really almost unparalleled, and I think we're going to see a new era in which you're going to see regenerative therapy play a major role in cardiovascular medicine. Thank you.
Thank you. That's a terrific lecture. Let's open it for questions. But John?
Yeah.
That was a brilliant overview. Thank you.
Thank you.
Thank you for that. I do agree with you that we've learned a lot from the clinical trials with stem cell therapy for myocardial ischemia and dysfunction. The later trials, the best controlled trials, the NIH-funded trials, have all been flat negative. And so I think we've learned something from that as well.
Yes.
One of the concerns I have with cell therapy, and of course I've been involved in the trials as well, and I'm hopeful as a clinician that we might get some gain from this. I understand there's a paracrine effect. The cells, as you pointed out, are not viable for very long in the tissue. We can't reconstitute the normal architecture of the damaged heart by injecting the cells, it appears. There's a modest paracrine effect. So one of the things that we're moving toward, and you touched on it, is directed differentiation. So to produce a cocktail or an agent that will transdifferentiate cells in the heart to a therapeutic cell type. So if you want more cardiomyocytes, so if you want more endothelial cells, if you have a cocktail that can enhance the transdifferentiation of fibroblasts that are migrating into that area of injury that are going to form a scar, if you can transdifferentiate some of those fibroblasts into endothelial cells, for example, now you have the microvasculature that will provide the nutrition and the niche for true cardiac repair. So that's something that we're working on. You mentioned the work with transcriptional factors, and those have been delivered by retroviruses, and or adenoviruses like Todd Rosengart, which is a little bit more clinically feasible. We're getting away. We're using a non-viral approach, using factors that enhance epigenetic plasticity and enhance the transdifferentiation. So maybe tell us a little bit about what your thoughts are about that, about moving more toward a small molecule approach for regenerative medicine.
Well, you've got one of the leaders in the field here, and you've asked all the right important questions. And if I didn't make it clear, I think where the field is going is that we can do a lot of things to induce the differentiation of cells into a functioning myocyte, like the allogeneic MSC. But I think the winner is going to be the understanding that we need pre-differentiated cardiomyocytes to embed and survive and go forward. And I think the inducible pluripotent cells, I think these cocktails of genetic engineering may well be the story, because we can markedly enhance survival, but maybe not long enough to have this really profound stimulation of the repair. So I think these transcription factors and genetic engineering to cells that are pre-differentiated to a myocyte lineage is probably going to be the winner in the short term. I think that your second question was regarding where we're going with small molecules and so forth. I think that's where we're going to end up. I think we're understanding, whether it's from exosomes and now we can develop a drug from that, or how we get to small molecules that are really the critical players in the expression that are coming from the cells, I think that's where the field is moving. And you're on the front end of that thinking, so I agree with everything you've suggested.
That'd certainly be easier. Les, let me just have you close with a comment on the development of the field in cell-based therapy. It requires collaboration with industry. I think that if you take a product that's not patentable to rapidly develop into clinical practice, it's a great challenge, because there's probably not enough money in the system, in the government, or in the small institutions to launch large trials that will lead to regulatory approval. So what are the companies doing to make a cell that's not patentable, or a gene, potentially commerciable? What is the strategy? What's happening that allows a company to develop? And what is it that they're doing to make that happen?
Another incredibly important. I didn't particularly like to get into this, but one of the biggest liabilities or limitations in the field has been that the Supreme Court has offered an opinion that anything that exists in nature is not patentable. If you develop a drug that is functional in a pathway in the body, that's different than if you're developing a cell that is a naturally occurring cell in the body. And so that inability to have intellectual property that you can then lock down your cell, your gene, has limited Big Pharma from getting in. But it's kind of the subtext that they just had a Wall Street review about a year ago, and 20 of the biggest Big Pharmas in the world were present. 80% of them have an in-house cell therapy platform that they're working on. Johnson & Johnson offered $350 million for the CARDIOCEUS if that trial goes forward and is positive. So there is an investment in this. The area of the iPS cell and the pre-differentiated cells that are not normally in the body, even embryonic, are seemingly patentable. And these genes, again, you're doing things you can modify. So it's had somewhat of a numbing effect on the field in terms of the big upfront investment like you'd see in pharma. But I think that there's so much progress going forward. It's going to be more first to market, best outcome, best strategy. And I think that's where the field is going to go.
Thank you, Les. It was a fantastic lecture, so thank you for the time and sharing this experience with us.
Thank you for inviting me.
Thank you.
Did I convince you at all?